All right, good afternoon. We're still talking tactical emergency casualty care. We're going to be talking about indirect threat care, warm zone. Usually what that means is that you are not going to be you're not going to be in the line of fire essentially or in the danger zone, but you are going to be in a place where anything can change. So you have to make sure that when you're with your patient that you are quick to move out of there or clear out of there along with your patient. So right now we're going to go over hypothermia. Hypothermia is just something that is produced by shock specifically. So you want to make sure that the patient is not in wet clothing. If you need to remove it, cut it off and then try to replace it with dry clothing. What you're going to do is if you have any commercialized blankets, you're going to put it on the patient and make sure that the patient stays covered and warm. The other thing that you can do is you can take like saline bags such as these, warm them up in the microwave anywhere between 10 to 20 seconds, and then try to do an IV solution so that you're putting warm fluids to the patient. Another thing you can do is if you have a commercialized product that if you crush, you can develop essentially heat from that chemical reaction. You can put these in the areas such as the groin and the armpits. Again, the idea is to keep the patient warm and make sure that the patient's out of hypothermia. All right, guys, in the next video, we're going to be talking about reassessing your patient. This is again in response to indirect threat care, the warm zone. This is part of the Tactical Emergency Casualty Care for EHS 3105. My name is Andrew Acevedo. So reassessing your patient. So you've already taken care of kind of the initial survey, you've dealt with all the life-threatening injuries. Now you want to go back and see if there's anything else that you need to take care of intervention-wise. So you're going to do a quick sweep. You're going to see if there's anything that you missed, that blood's coming out, maybe something that wasn't patched correctly or anything like that. And then as well, you want to make sure that at this point you can actually treat fractures. So there are two types of fractures. They're going to be open and closed fractures. Some are going to be really obvious to see, and then others you won't be able to see, but you'll be able to hear something that's called crepitus, which is a grinding bone-on-bone noise. So if that happens, you have some commercialized products such as Samsplint like this. All you have to do is take this, open it up. It's very rigid and it molds to whatever you're going to put it on. And then when you take it out, you just mold it to wherever you want to splint. And then if you need to go any further, you can take some medical tape to secure it appropriately. And then finally, you want to check for pelvic fractures. So what you want to do is you want to go to the pelvic area and then you want to push, essentially closing a book and pushing it in. And if you feel that there's instability, then more than likely that is part of a pelvic fracture. So you want to take a commercialized device. Usually they have things for like pelvic fracture splintings. But other things that you can do is you can take some pillows, you can tape it up, anything that can pretty much prevent any movement of that pelvis any further than it needs to go to not create any more damage or issues. Okay, let's move on to the next video. All right, the next video that we're going to be talking about is going to be burns. Obviously, if the patient is actively burning, you want to take some kind of blanket or something to kind of stop the burning process. The next thing you want to do is you want to evaluate the patient, the skin specifically, and if you see that there are any burns, you want to take a dry sterile dressing or something that's going to be dry in nature so that you can place it over the wound. You want to cover them, prevent hyperthermia, because obviously that skin surface has now been broken. So it's going to cause them to go into shock because of hypothermia. So by putting that dry sterile dressing, you're going to be protecting that patient as well. The other thing to take into consideration is going to be facial burns. Facial burns, you should be seeing some kind of like burn, charring around the mouth area, sometimes in the throat. If that has happened or has occurred, you want to start thinking that you should be dropping some kind of intubation into that patient. The only reason for it is because you have smoke inhalation. When the patient breathes in, all that burning heat is going to burn down their esophagus or trachea, and eventually is going to cause swelling. So if you drop in an intubation tube, then you can prevent the swelling and the closure of that airway, and then you'll have more problems later by doing a cricothyrotomy. And that's what you don't want to essentially get to, that like last resort point. So dropping an intubation tube will actually be the ideal situation for you. Again, there's also calculations out there for total body surface area. So you want to calculate to see how extreme or how much the extent of the burns are. If it's 10%, that's usually where you round off to. Anything greater than 20%, you want to start thinking fluid resuscitation. One thing you do have to take into consideration is hemorrhagic shock does take precedence over burn fluid resuscitation. So you should follow the protocol for hemorrhagic shock. But if you need to do fluid resuscitation, start that immediately so that way you know that the patient's going to have fluids and it won't be losing any fluids from the burns, at least the greater than 20% burns. All right, let's move on to the next. Okay, the next topic we're going to be talking about are analgesics. This is usually going to be when your patient is in pain, so you have to kind of moderate and essentially deal with pain control depending on the level that you assess the patient to be. So you have your mild to moderate pain levels. Those usually require like the non-steroidal anti-inflammatory drugs such as ketorolac, you have Tylenol, you have aspirin, and then you have naproxen. Those are really good for those type of like mild kind of pain things that you want to just kind of deal with and kind of help them mitigate that. The one thing that you do have to take into consideration is if the patient is actively bleeding, you don't want to inhibit that platelet clotting function. So you have celecoxib and you have acetaminophen, also known as Tylenol. Those are going to be like your Safeway NSAIDs that are going to not interfere with that clotting process for the platelets. Now, if you have moderate to severe pain, you have things such as morphine and you have also fentanyl. Sometimes fentanyls come in lollipops that they can kind of suck on, and then morphine obviously has to be given IV. Sometimes it can be given IM, but IV is usually the best way. The only thing taken into consideration is that if you've had any injury to the brain, if you had any essentially not hypotension, but if they are hypotensive, or that you feel like they have some kind of respiratory depression going on, then you want to stay away from those drugs. The thing that you do want to use is ketamine. That is much safer. The only problem is that ketamine is short-lived, so you're going to have to keep doing it over and over again, but at least you know that you can administer a strong drug that's going to be able to deal and handle the pain that you're dealing with. The one thing that you should take into consideration is that if you are going to be administering morphine, or if you're going to be administering fentanyl, then you have something like naloxone if you want to reverse the effects. For some reason, if you didn't catch anything, at least you have that option to kind of hopefully save the patient and not have to go into the whole CPR and then having to deal with that mess. Let's move on to the next video. Our next topic is going to be on monitoring your patient. So normally you'll be equipped with some kind of device to be able to monitor them. Sometimes you'll be given some kind of like wrist strap or anything like that to be able to monitor for heart rate and things like that. You'll have an SpO2 to measure kind of the levels of oxygen in the blood. Sometimes you won't be having any of those things, and then you could use something as simple as a stethoscope and a blood pressure cuff to be able to see if you can tell the heart rate. So whatever you do have, use those resources to be able to check. Even a simple pulse check is enough for you to be able to tell if the patient's adequately perfusing, if they're going into shock, any of those things that you need to try to see. Also monitoring for airway, breathing, those are also great helpful tools that you can do on your own without having some kind of fancy machine or anything like that. But again, continue to assess your patient. If they've been through a traumatic event, you want to do it every 5 minutes. If they're kind of stable, then every 15 minutes suffices. Okay, our next topic is going to be on preparing the patient for movement. So obviously, depending on what your resources are, you'll have either some kind of spinal board, a litter board, anything that's commercially made to transport a patient. Sometimes you'll have like a basket type board to be able to be lifted off of like the helicopter for extrication. But whatever you have, just make sure that you place the patient onto the board safely. Make sure that if you have to follow spinal precautions, that you are following those, that the head and the spinal area is secured appropriately, and that you secure the patient snugly enough to be able to fit into the board, not fall out if movement is occurring, and also still being able to check and reassess the patient constantly for like vital signs and any injuries and interventions. Our next topic is going to be on communication. This is very key when it comes to a patient. Usually a patient is kind of freaking out at this point. They're very on edge. They're very scared. This is where you come in as a provider and you reassure them. Make sure that you explain everything that you're doing so that they're part of that process every step of the way. Make sure that you're constantly giving them feedback, that they're doing well. Make sure that you're making sure that they're good to go with everything that you are doing, so that you know what you are doing and that you are trying to keep them safe. This is going to go a long way, especially with the patient that is scared and is in a very traumatic state. So communication is key when it comes to taking care of a patient, especially in emergent situations. The next topic we're going to talk about is CPR. Obviously, you possibly have already performed CPR, you got your patient stabilized, you've done your interventions, you've done your secondary surveys, but at any point during the whole process of taking care of the patient could end up having to need CPR again. So if that happens, just remember your basics, right? So no breathing, no circulation, and then also unconsciousness. That happens, you should start considering to do CPR. If you have an AED, make sure you have that with you handy. That might be a possibility, especially when it comes to like electrocution and stuff like that. And also if you have a commercialized BVM, you can use that as well, but you don't need it. You can always do CPR as basic as just, head tilt, chin lift, or jaw thrust, depending on the situation, opening the mouth and the airway, and then breathing into the patient. So just remember those things when considering CPR, that at any point this could reoccur again. Do not lose sight or thought of the fact that CPR may be required at a later time. And finally, let's finish up with documentation of care. So anything that you do with the patient, any drugs that you push in, any type of interventions, any tourniquets, anything that you do to that patient, you want to make sure that you document it. Documentation is key. The reason for that is when you pass it on to the next echelon of care, they're going to want to see what you have done for the patient. That's also going to be really good for you to track everything that you've done for later series in case it becomes something legal in nature, or whether there was like a mishandling of care or anything like that. But if you document everything and you do everything appropriately, then you shouldn't have to worry about this. So make sure you put the time, the date, make sure you put how long that intervention was assessed for, how long it lasts, and then make sure that you put whether or not the patient destabilized or stabilized. Put how often that you're doing it, and then everything should be good to go.